Hi everyone. In this section, I'll be discussing the recall-based pharmacology question that occurred recently, that is INI-CET July 2021. So, how was the paper? I think it was moderately okay. And the pharmacology questions, I think most of them were single-liner questions, and some of the students told it as moderate to tougher. I hope this type of questions are neither the AIMS pattern. It's like more of a JIPMER pattern of questions where they take from either the standard journals or they take it from the standard textbook like Goodman and Gilbert. So, with that background, let's start discussing what are the questions asked in pharmacology and what are the answers for them. So, all these questions are recall based and there will be some options altered, and that's why this is being framed all because of your feedback, your opinions. With that, we have framed those questions. So, without wasting much of our time, so let's proceed. So myself, Dr. Bharath Kumar, I'm the pharmacology faculty in eGurukul and DBMCI. So we'll start with this question. Which of the following thiazide diuretic, which of the following thiazide diuretic is used in renal failure, that is GFR less than 30 ml per minute? Now remember, the diuretics, particularly thiazide diuretics, they don't work in renal failure. So they don't work in renal failure. So there are only two diuretics which can work in renal failure, severe renal failure, and one is indapamide and one more is metolazone. So both will work. So this is a reference taken from Goodman and Gilman, and he has clearly mentioned that both of them can work in severe renal failure. Now, if you read KD Tripathi will give only one option, that is metolazone can be used in severe renal failure. So both are correct answer, but the better one goes with this metolazone. So that is a better option compared to both of them. So other than that, thiazide diuretics are not useful in renal failure. And remember, can we use loop diuretics in renal failure? Yes, you can use loop diuretics in renal failure, and they will work there. Now, now, this was the thing we discussed in the eGurukul as well as in our classes. Now, these are thiazide diuretics, and in the classes, you see indapamide, metolazone, they work in renal failure. So, we have discussed these points, and unfortunately, they have given both the options here. And Goodman Gilman clearly mentions both of them, both of these drugs can be used in severe renal failure. But only the KD Tripathi will tell you that metolazone. So, here once again, the controversy has been raised by the examiner. Now, this is what the Goodman and Gilman tells you. So, read this. With the possible exceptions of metolazone and indapamide, most thiazide diuretics are ineffective when the eGFR is less than 30 to 40 ml per minute. So, this is the exact line which is taken from the Goodman and Gilman. So, here is excluding both metolazone and indapamide, which are both the right answers. Right. So I've given the fact. So it's up to you to decide. And KD Tripathi will mention only the metolazone. Right. So let's move on to the next question. Topiramate is used in the treatment of. So this is the exact line what I got from the students. Topiramate is one of the drug which is approved for the seizure disorder like generalized tonic-clonic seizures, and it is also approved for the migraine prophylaxis in adults. It is also used for migraine prophylaxis, and it's not the main drug but it's adjunctive drug, that means additional drug in the management of Lennox-Gastaut syndrome. So Lennox-Gastaut syndrome, it's an adjunctive drug. So here also they have created a controversy. Now whether it is migraine or LGS, ADHD, dementia. Now mainly the drug is mainly used in the treatment of migraine. So if both are given the option, we have to go for the better option, and a better option will be for migraine prophylaxis treatment, right? And LGS, it's an adjunctive treatment, so the better option will always be the migraine. So migraine, it is used. Now, this is the point which we discussed in the class. Topiramate, it's a mild carbonic anhydrase inhibitor. It's a sodium channel blocker as well as AMPA blocker. It is used in generalized tonic-clonic seizure, partial seizures, and migraine prophylaxis. Now, additionally, it is also being used to decrease craving in alcohol and obesity. These are off-label uses. But remember, it is mainly for GTCS, that is seizure disorders, as well as for migraine prophylaxis. And one more is adjunctive therapy in Lennox-Gastaut syndrome. These are the FDA approved indications, right? So we'll go with the migraine for that. Now, drug used for long-term management of obesity is. Now, sibutramine is already banned. Nobody is using that. So that is excluded. Nobody is used for longer treatment because they increase the risk of cardiovascular death. Similarly, fenfluramine is not used. And option C is metformin. So typo error. Metformin. Now remember, most of the authorities claim it to be weight neutral and it may cause mild loss. Now that doesn't mean that it is used in the treatment of obesity for a very long time. The drug that is used is liraglutide, which is specifically approved for the management of obesity. Is a GLP-1 agonist. Now it is used for diabetes type 2 as well as in the management of obesity for long-term weight management. So the answer for this question will be option D, liraglutide. So liraglutide will be the best option here. Now this is what we discussed in the class. Fenfluramine, sibutramine, they are banned due to increased cardiovascular death. So nobody uses it for a very long time. What we use is the combination of phentermine and topiramate. We also use combinations like bupropion with naltrexone and zonisamide. They are also used. Newer drugs, we had lorcaserin, but it increased the risk of cancer. So that's why it is banned now. What we use now is GLP-1 agonist that is called liraglutide. So recently a drug called semaglutide is also being used for that. It's a orally also it is available. So what were the older drugs available? One was the cooking medium that is called Olestra. Then the inhibitor of lipase is Orlistat. Now cannabinoids, they stimulate appetite, and the antagonist was rimonabant that is banned now because of the adverse effect of the drug, and leptin is an endogenous slimming peptide. Now the answer is liraglutide. Now inhaled nitric oxide. So we discussed this concept when we discussed nitrates also, when we discussed pulmonary hypertension also. Inhaled nitric oxide is one of the favorite for the AIMS people. So first they asked what is the mechanism of nitrate. It increases cyclic GMP. It is the mechanism how it acts. So because of increasing cyclic GMP, it activates protein kinase G, which will inhibit the phosphorylation of myosin light chain kinase. So that will cause smooth muscle relaxation. If it is a blood vessel, vasodilation. Now, is it used in migraine? No, because migraine itself is because of vasodilation and it will exaggerate that. Pulmonary fibrosis? No, it is used for pulmonary hypertension. So this is the right answer for inhaled nitric oxide. Particularly in case of pediatric pulmonary hypertension, this inhaled nitric oxide is being used. Now, what about Parkinson's disease? No, it has no role in Parkinson's disease. So the right answer is pulmonary hypertension. So this was discussed in the class also. Now what are the drugs for hypertension, pulmonary hypertension? Diiodopridines like nifedipine and amlodipine, non-diiodopridine diltiazem, PGI2 analog like epoprostenol, treprostinil, and prostacyclin receptor agonist that is selexipag, phosphodiesterase 5 inhibitors, sildenafil, tadalafil, inhaled nitric oxide. Particularly they are useful in pulmonary hypertension in neonates. Endothelin receptor antagonists like bosentan, ambrisentan, oral soluble guanyl cyclase agonist, riociguat. Investigational new drug is fasudil. Now, even this topic is small, but the investigational drugs are more, and that's why pulmonary hypertension drugs are going to be asked. So that this time they are asked inhaled nitric oxide. Yes, moving on to the next question. An elderly lady on cancer therapy for metastatic breast cancer. She had pancytopenia. We don't know whether they had mentioned pancytopenia or not, but whenever there is cancer chemotherapy, obviously it will decrease RBC. So this will lead to anemia. It will decrease platelet, thrombocytopenia, and as well as it will decrease the WBC count, which will lead to leukopenia or neutropenia or whatever. So now she presents with fever. Which antimicrobials cannot be used empirically in this patient? Now what about cefepime? Cefepime is a 4th generation cephalosporin which can cover gram-negative bacterial infections. Piperacillin plus tazobactam can also be used, which will cover the Pseudomonas. Linezolide, the problem with linezolide is it can cause bone marrow suppression. Now the point is, when she is on cancer chemotherapy, she already have bone marrow suppression because of cancer chemotherapy, and she is having pancytopenia. Now if you use linezolide, it will suppress further, so there will be a decrease in neutrophil count, decrease in WBC count, so the infection may flare up further. So that should not be used in this patient because of the problem associated with linezolide. Meropenem, yes, it's a group of carbapenem group of drugs which can be used. Right. Now, this was discussed during oxazolidiones. We discussed the mechanism. What are the adverse drug reactions is bone marrow suppression. And many a times when we use this drug, linezolide, we monitor platelet count, we monitor complete blood count, CBC. So it decreases platelet, decreases neutrophil count. So if you are using it for more than 4 weeks, it can also cause optic neuropathy and peripheral neuropathy. So these are the other complications with linezolide. Very beautiful drug, but these are the complications. Now this was an image based question, and this is what the students had told, and there was transglycosylase, there was enzyme shown. Which of the drug will inhibit transglycosylase? The drug is vancomycin. So vancomycin inhibits transglycosylase enzyme, which is required for cell wall synthesis. Now cephalosporin inhibits transpeptidase, which is required for cell wall synthesis. Now linezolide, it binds to 23S fraction of 50S ribosome and it inhibits protein synthesis. Amikacin also binds to 30S part of ribosome. What are the drugs which bind to 30S? It is tetracycline and amyl glucoside. So thereby it inhibits protein synthesis. So this is what the question was asked. The mechanism is inhibitor of transglycosylase is vancomycin. Yes, so this was the question. We discussed what are the cell wall synthesis inhibitors. We gave the mnemonic BBC, found ghost. So glycopeptides, remember, they inhibit transglycosylation. Beta lactams inhibit transpeptidase. Besitracin inhibit bacterphenol synthesis. And cycloserine inhibit alanine racemase and D-ALA-DL ligase. And phosphomycin inhibit enol pyruvyl transferase. So this was discussed in the classes, right? So this was discussed. Now moving on to the next question, what happens when you double the dose of a drug following first order kinetics? Now the options, many students gave a different options here, but still we have tried to collect this. Half-life same and plasma concentration double, both same, half-life doubles and concentration remains same. Now first we'll understand what is first order kinetics. That means constant amount of drug eliminated in unit time. For example, we are giving 8 milligram. 8 milligram will become 4 milligram, let us assume in 2 hours, and 4 milligram will become 2 milligram in 2 hours. So first order kinetics means every unit time a constant fraction of drug is eliminated out, that is half. So first order means the fraction eliminated is constant, that is constant. Second one is the half-life, that is to reduce the drug from initial plasma concentration to half its original value is T half. So T half remains constant here. Even if you double, the T half remains the same, it will not change. So what happens to the concentration? Concentration increases. When you double the dose, obviously the concentration increases. Now what happens to the clearance? So clearance also remains constant. Now what about concentration and elimination rate? As we increase the concentration of the drug, the elimination rate also increases. So these are the basics. Now let us go with this half-life same and plasma concentration doubles. So if you increase the dose, obviously the half-life remains same, plasma concentration doubles. Suppose you are giving 4 milligram and suddenly you double the dose, it will go to 8 milligram. But will the half-life change? No. But only thing is the drug duration of action increases, that's it. The duration of action increases by 2 half-lives, that's it. But the half-life will remain the same. That is the specialty of first order kinetics. But in zero order kinetics, the half-life is variable. How variable? If you increase the dose of the drug more and more, the half-life also increases. Both will double? No. Both will be same? No. Half-life doubles? No. It will not double. What doubles is the duration of action. It requires 2 half-life will be increased. So this was one of the question which was taken from USMLE pattern of exam, right? So this is also ruled out. So the right answer is this one. Now even students have given me the answer like elimination rate. Yes, if concentration increases, we know that the elimination rate is directly proportional. So if the drug concentration increases, elimination rate also increases. So that is the specialty of first order kinetics. But what about zero order kinetics? In zero order kinetics, the concentration if increases, the elimination rate remains constant. So it will not vary. Whatever concentration you will increase, the elimination rate is constant. The half-life is variable, clearance is variable in case of zero order, and in zero order, constant amount of drug is eliminated in unit time. So same thing we have discussed in the classes. So this was the example given, constant fraction of a drug, zero means constant amount. See here you can see the example. Suppose I gave 2 milligram and I doubled the dose, it become 4 milligram. Now the half-life remains same, 1 hour. It will not change. So TF is constant and elimination rate is variable. So it is directly proportional to plasma concentration, and the clearance of the drug is also constant here. But in zero order, the half-life is not constant. Now remember, one more question they ask you is how many half-lives are required to achieve steady state. Now that can be determined only if it follows first order kinetics, because half-life is constant. So where you can tell it requires 4 to 5 half-lives to achieve steady state. Now first order kinetics is followed by majority of the drugs. Only few drugs follow this zero order or saturation kinetic or mixed order kinetics. We have given a mnemonic watt power for that. Okay guys, so this order of kinetics is one of the favorite for examiners and even for JIPMER, because JIPMER people are very favorite. One time they had asked the dose of morphine. For example, they gave like this 2 milligram, 4 and 8 milligram. So patient came after 4 hours of ingesting morphine. So what was the initial dose? So 4 hours after the patient comes, the initial dose that was taken was 8 milligrams. So the first order kinetics was asked in this way, right? So order of kinetics is one of the important thing what you have to concentrate in this INI-CET pattern of exam, because here 3 institutes are framing the questions for you. One is AIIMS, JIPMER and NIMANS, right? Come on. So coming on to the next one. Now, which is not priority among these for essential medicine list? Now, what is essential medicine is nothing but a medicine which should be available in affordable form. So everybody should afford that, and it should show very good efficacy. It should be safe, and the cost should not be too high, and it should be present, and the disease should be present relevantly. For example, diabetes is common in India, hypertension is common in India, snake bite is common. You should get anti-snake venom. There are certain countries where the snake is not there, and what is the use of anti-snake venom there? So it is not an essential drug list drug there. So essential drug should take care of 4 things. One is the drug, the disease should be prevalent. Now the efficacy should be good, and it should be safe. It should not cause so many adverse effects, and the cost. So these are the 4 things to tell it's an essential medicine. Now let us see cost benefit ratio. That means the cost. Now how much you spend and how much benefit we get derived from it. If it is good, then that is fine, essential medicine. FDC combination, it's not a criteria. It may be a single drug or FDC. That doesn't mean a criteria for us. Large clinical safety, yes, that is required. Prevalence of the disease, yes, this is very, very important. So we don't tell for a rare disease it is an essential medicine. Now this was discussed in eGurukul. So we discussed evidence-based medicine and essential medicine. I gave an example of bodybuilding and diabetes, hypertension. So it depends on the priority health needs, that is prevalence, must not be expensive, that is cost effective. It should be safe, and it should show efficacy and or effectiveness. So these are the 4 features of essential medicine. So WHO is the one which prepares this list, and every country, after they prepare the list, from the list they will prepare according to their country. I told you, in India we have snake bite, so we should have anti-snake venom. There may be a country where there is no snake bites, so they don't prefer them as essential medicine. And very, very important, particularly this type of questions are asked in AIIMS. So AIIMS people are very much interested in asking this. And next one is evidence-based medicine. So that is going to be asked in the future exams to come. Right. Now moving on to the next question. Now nivolumab. So whenever a new drug or a MAB or a tyrosine kinase inhibitor is asked, so that is particularly a JIPMER pattern of exam. So usually how many new drugs can you remember as a student? First of all, you have so many things to read, and how many things you can remember. So nivolumab is one of the toughest question, because nivolumab uses are many uses. First of all, you should remember it's a programmed death cell ligand 1 blocker. and then you have to remember its uses. Now, the major use of that drug was in melanoma. But apart from that, this drug is also approved in Hodgkin's lymphoma, renal cell carcinoma, and squamous cell carcinoma of head and neck, non-small carcinoma, cell carcinoma of lung, and urothelial carcinoma. So these are the other conditions where it is approved. Now, as a student, first of all, memorizing is very difficult, and these are all memorizing questions, and they are just given to make the paper tough, and we don't think these things will be repeated again. These things will be repeated again. So let us see here. Nivolumab is used in it is used in the Hodgkin's lymphoma, not in medulloblastoma, retinoblastoma, thyroid cancer. So the newer questions, maps, they are all JIPMER pattern of exams which have come back. So that's why the case-based questions will be very good because they have some logic. These are all memory-based questions, right? So once you have finished pharmacology, you have time, then only you can go for these type of questions. And that too, if you read in textbook, all these uses are not given in textbook, right? So this is to be read with articles, with the journals like that. Now moving on to the drug, which drug is not used in polycystic ovarian syndrome? Now yes, clomiphene citrate is used in polycystic ovarian syndrome to induce ovulation. OCPs are also used. Metformin is also used because in PCOS it reduces the insulin resistance, and one of the major drug which is used. Tamoxifen mainly is used for breast cancer. Off-label it is used in PCOS, but it's not a main drug for PCOS. So mainly it is used for premenopausal and postmenopausal breast cancer, which is hormone-sensitive breast cancer. That is tamoxifen, which belongs to the category of SERMs. So it belongs to SERMs category, right? Yes. Now treatment of sideroblastic anemia. Now you know that vitamin B6 deficiency can lead to sideroblastic anemia, and same thing you can compare with isoniazid. So whenever isoniazid is given, it can also manifest with sideroblastic anemia. So what we supplement for this sideroblastic anemia is vitamin B6, that is pyridoxine. Now pyridoxine has application. Pyridoxine has application in pharmacology. One is pyridoxine is given with INH if there is peripheral neuropathy. Pyridoxine should not be given with levodopa. That is one more application because the levodopa into dopamine in the periphery, that is done by an enzyme called peripheral decarboxylase. This enzyme is stimulated by pyridoxine, and that will decrease the efficacy of levodopa, right? And nowadays they ask this question also, sideroblastic anemia, the treatment is vitamin B6. What about iron? Iron is for iron deficiency anemia, and folic acid as well as vitamin B12, they are mainly for megaloblastic anemia, and iron for iron deficiency anemia, right? Now moving on to the next question. Now mechanism of paradoxical bronchoconstriction Ipratropium bromide is due to. Now this is one of the lines that has been taken from Goodman-Gilman, and that was covered in the eGurukul also. And what is the reason for that? One is benzalkonium chloride, pre-junctional M2 receptor stimulation, use of hypertonic saline, and due to irritant action of the drug. Now, why this causes bronchoconstriction has been proposed by two theories. One is the presence of benzalkonium chloride in the drug preparation, and also EDTA in the preparation, which is responsible for this bronchoconstriction. Second one is, the reason is, this drug Ipratropium bromide has affinity for a receptor on presynapse. Now this receptor, what is the function of receptor? Let me tell you. The function of receptor is to decrease acetylcholine release. Now when I use ipratropium, what is ipratropium bromide? Ipratropium bromide is a blocker of muscarinic receptor, so it mainly blocks M3 receptor. Along with that, it can also block the M receptor which is present in the presynapse. Now when it blocks that, there will be increase in acetylcholine, and you know that parasympathetic system can cause bronchoconstriction. So that is why it may produce paradoxical bronchoconstriction. Two theories have been proposed. One is by benzalkonium chloride, which is used in ipratropium preparations, and pre-junctional M2 receptor stimulation. It's not because of stimulation, it is because of the blockade of pre-junctional, and that's why there will be increased acetylcholine. So was it discussed in eGurukul? Yes. So this was the notes. Ipratropium bromide, it causes paradoxical bronchoconstriction. Why does it cause it? One is because of EDTA and benzalkonilamine present in the preparation. Second one is because of the M2 blockade, which is going to increase acetylcholine release, which is present presynaptically. So this will lead to bronchoconstriction, right? Now you may ask a question, why not tiotropium? Now tiotropium doesn't have that affinity, and it mainly blocks the M3 receptor mainly and very minimal on M2. So that's not seen. And also these preservatives are not there in tiotropium. So that's why only with that we see this problem, not with the other newer preparation like tiotropium, glycopyrronium, and imeclidinium bromide. So there we don't see this problem. Yes. Now moving on to the next question. Now this is one more tricky question. Not an off-label use of risperidone is. Now what is risperidone? You all know that risperidone belongs to atypical antipsychotic. Now what do you mean by an atypical antipsychotic? An atypical antipsychotic blocks the receptor 5-HT2 more than D2 receptor. That is atypical. Now the specialty of risperidone is if you use it more than 6 mg, so it can also block D2, and what you can see is extrapyramidal symptoms as well as hyperprolactinemia. Now they have asked not an off-label use. Now OCD it is used, bipolar disorder it is used, dementia it is used. It is not used in post-traumatic stress disorder. It is not used there. So where do you use risperidone? It is mainly in case of schizophrenia, that is psychosis. Now it is used for autism, particularly to decrease the irritability in autistic child, and also in case of bipolar disorder, and mainly it is for acute mania phases it is useful. So these are the FDA approved indications. Now off-label, it is also being useful in OCD, and also it is useful in dementia, and also it is useful in some of the delirium conditions. So these are the other important off-label uses of this drug. Now coming to this, the answer is post-traumatic stress disorder. Now this was the exact line that was taken from Goodman and Gilman. See here, recent data do not support routine use of risperidone for post-traumatic stress disorder, right? So it will not support the use, but it can be used in other OCDs. Yes, it can be used for obsessive compulsive disorder. So all these are directly taken from Goodman and Gilman. If they are quoting Goodman and Gilman, obviously it is probably from a GPMR point of view. Yes. Now moving on to one more question. A patient on retigabine. Now remember guys, retigabine is also called as ezogabine. He has taken this for epilepsy. Now this patient was added on phenytoin therapy. What will you do next? That's the question. Now ezogabine or retigabine, usually they are used for partial seizure. Now whenever we use this ezogabine and we add a drug called phenytoin, what should we do? Now first understand what is phenytoin. Phenytoin is an enzyme inducer. Phenytoin is an enzyme inducer. Now when you use an enzyme inducer, what happens when you use one more drug which is metabolized by the enzymes, that is ezogabine or retigabine, the duration of action decreases. So what should I do when I combine with the enzyme inducer? I have to increase the dose of ezogabine and give. Otherwise, the ezogabine duration of action decreases because it's enzyme inducer. It's an enzyme inducer. So what should I do here? What I can do is I have to increase the dose of ezogabine. So should we decrease the dose? No. Stop retigabine. Never stop any anti-epileptic abruptly. So it should be gradually withdrawn. Remember, this is very, very important, guys. Any anti-epileptic should not be gradually withdrawn. So it should not be stopped abruptly. It should be gradually withdrawn. Suppose you are taking a old drug, you are giving a old anti-epileptic drug. So those doses should be decreased gradually and then stop. The new drug should be gradually increased. So this is what has to be done. So you should never stop this drug and add one more drug. The reason is there is always a risk of a seizure. So that's why. Change retigabine to carbamazepine. That is not required because the drug is working, and along with that we are using phenytoin. So better increase the dose and keep. Now one more point, remember, when we use carbamazepine, now we give carbamazepine for partial seizures, Now, patient was well controlled with that, and after 3 months, he comes with again partial seizures. So, guys, should I increase the dose of carbamazepine, decrease, or should I change the drug? What should I do? So, this is the next level of question. Now, carbamazepine, if the patient presents with again seizure episode after 3 months, you should be increasing the dose of carbamazepine because carbamazepine itself is an auto-inducer. The meaning is it can induce its own metabolism and decrease its level. So in that case, after 3 months, if the patient who has well controlled and comes with the seizures, what is the thing what you go do is increase the dose of carbamazepine. So this is what we can do. So similarly, these are the type of questions which are to be asked. Now, combination therapy not useful is, now gonorrhea is a sexually transmitted infection and the drug of choice is ceftriaxone. So monotherapy is possible, but to prevent resistant issues, either we have to give it with doxy or azithro. Now they will also take care of non-gonococcal urethritis also. That's why the combination is preferred. And second one is to prevent a resistant issue. Tuberculosis, you all know that a single drug will not work. So to prevent resistance, we have to use HRZD if it is sensitive, that is drug sensitive tuberculosis. Malaria, what we use is artesunate combination therapy. If it is falciparum or malariae, or if it is Vivax or Vowel, we use chloroquine plus primaquine. So primaquine for radical cure, which is given for 14 days. So here also it is a combination of drug, not a single drug. Now intraabdominal infections, you can give single drug. There is nothing to give a combination of drug. And if you know the specific organism, then depending on that you can give single drug. There is no need to give a combination therapy in case of intra-abdominal infections. So the right answer is D, intra-abdominal infections. Yes, moving on to the next question. In a patient with HIV and tuberculosis co-infection, what should be done? So patient has come to your hospital. He has both HIV and tuberculosis. What should be done? ATT first, then ART. Start both simultaneously. Start when CD4 count is less than 350. ART first, then ADT. Now, when the patient comes with both the infections of HIV and tuberculosis, now what to be started first? Should we start ART? Now, the problem is when you start ART, immediately there will be something called immune reconstitution inflammatory syndrome if already there is an infection. So this will cause more problem to the patient. So that's why when you are using this treatment therapy, first you have to treat TB. So start TB treatment, that is ATT, to prevent that IRIS, that is immune reconstitution inflammatory syndrome. Then after around 2 weeks, you start with ART. So this is the ideal way. Otherwise, if you do ulta, what happens? When you give ART, the immune will get activated, so it will start fighting the inflammation. So that's why first you have to give the tubercular therapy. And should we give a long gap? No. If you give a long gap, because the HIV is also multiplying, we should not take a risk. So we have to start ART later. Now, will not IRIS occur after that? Yes, it may occur. Then you can treat it with NSAIDs or steroids. But always take care of tuberculosis first and then ART. So never start them simultaneously. Now we don't take CD4 into consideration while treating HIV now. So whatever the CD4 count, the government has funded so much, it can be started without any CD4 count. Any HIV positive, start with that drug. ART first, then ATT, so this is not followed. So that is one of the questions which is being repeatedly asked. It's an application based question because many of the primary health center, they get this type of cases and they don't know what to give first. And they have protocol they will give, but they want to ask you and get the answer from you. Now coming to one more question. Patient was given prophylaxis with clopidogrel for stroke. So he was given clopidogrel for stroke prophylaxis. He presented with stroke. What could be the reason? Now remember, in pharmacogenetics also and in pharmacokinetics also, I was telling you, clopidogrel is metabolized specifically by the enzyme CYP2C19. Now this cytochrome enzyme like CYP3A4, these are the enzymes which metabolize the drug. These are called microsomal enzymes. Now enzymes means they are nothing but proteins, And if you want a protein, they are synthesized by genes. So genes will give us a protein, proteins are enzymes. So there may be a problem in the genes. Some people are defective in the genes. So mainly the problem in cytochrome enzymes occurs with CYP, 2C19, 2C9 and CYP2D6. So these are the enzymes where the pharmacogenetic problem occurs. Now, why this patient came with a stroke when we had given already clopidogrel? There may be a reason because of enzyme also. There are certain people whose enzyme, that is CYP2C19, is either defective or it is slowly hydrolyzing the drug, because clopidogrel is a prodrug and it will become active only by the presence of CYP2C19. Now, in few people who doesn't have this gene properly or they have some defect with that, this enzyme will not convert this into active. Now, even if you are giving clopidogrel to that, the drug is not working because they are not working faster to make it active. So this is what we mean by pharmacogenetics, and one of the favorite for JIPMER. So they will ask you pharmacogenetics. So the reason is the CYP2C19. So can you tell me one more drug which can inhibit this? A proton pump inhibitor is omeprazole, and this can inhibit the enzyme. And previous questions were about this omeprazole and clopidogrel. So if patient was taking PPI and clopidogrel, now clopidogrel didn't work. What is the reason? The reason is omeprazole. Now they shifted the question to pharmacogenetics, and I told in the classes also 2C9, 2C19 and 2D6. And do you remember codeine becomes morphin in the presence of COP2D6. Here also there will be poor metabolizers, that means they don't have this 2D6 properly. So in them codeine becoming morphin is difficult. So in them analgesia is not seen so much. So these are the pharmacogenetics correlation what we have in pharmacology, and that will be asked particularly in this institutional exams. Now moving on to the next question. Patient came with acute glaucoma with red eye. Many students told that there is pain in the eye also. IOP was 38. Obviously when IOP is 38, that is too high, and obviously pain in the eye will be there. So red eye, 3 differential diagnoses: conjunctivitis, scleritis and acute congestive glaucoma. Now patient anterior chamber shows aqueous flare and keratitic precipitates, that is KPs. What should not be given? Now it is a case of uveitis. You can tell it by aqueous flow and keratitic precipitates. It is in the anterior chamber, anterior uveitis. Now it's an inflammatory condition and patient is having glaucoma. So which drug should not be used? Now beta blocker, no problem. Mannitol to decrease the intraocular pressure. Acetazolamide, same thing. And prostaglandins, you know that prostaglandins itself are inflammatory. They itself are inflammatory markers, inflammatory mediators. So in inflammatory conditions, particular anterior uveitis, we are not going to use prostaglandin analogs. So the answer for this question is prostaglandin analogs should not be used if the patient has anterior uveitis. So that is the answer. Now similar question will be framed that a patient has come with acute congestive glaucoma and the triggering factor is the closed angle, that is the angle is closed. In that case, what drug should not be used? They are mydriatics because they close the angle between the iris and cornea. So that was the question previous years, and now they have upgraded their questions like this. Now moving on to the next one. Which drug is useful in severe pediatric COVID-19? Now guys, if you see the recent guidelines, all the drugs are gone. In COVID-19 means only 2 drugs. One is the steroid and one more is the heparin, that is the anticoagulants. So in severe COVID-19 in pediatric patients, favipiravir is not useful, remdesivir not useful, ivermectin not useful. So what is the drug which is used in severe pediatric COVID-19? It is a steroid. So many a times in a severe COVID means patient is admitted, you give IV drugs, IV steroids. So the answer for that question is D, steroids. That is the answer. Now this was one more question asked, incorrect match. You have to find out the incorrect match. Idarucizumab, dabigatran, yes. Dabigatran, the antidote is idarucizumab. We told in the class also. Remember dabi for ida, da. And Hexanet, I told you Hexa is there, Rivaroxaban, Hexa is there. So both. Now, andexanet and apixaban, yes, this is also an antidote. Now, siraparantang is still an investigational drug. So if they are asking investigational drug, they expect you to read articles, they expect you to read journals. So it's an investigational drug, and that is being investigated for oral 2A inhibitor, that is dabigatran. For that reversal it is used, and also for hexa bands, that is 10A bands, that is oral 10A inhibitors. For that it is being investigated, and also it is being investigated for heparin and low molecular weight heparin. So it is not being investigated for fondaparinux. So the answer is this. So it's an investigational drug, that is siraparantang, right? But still not being approved. It's still under the trials. Right. Now moving on to the next question. I didn't get the options correctly with that. 27-year-old HIV patient on ART drugs. He had migraine and took ergotamine. Patient came with pulseless and features of acute ischemia in lower limbs due to. Now, pharmacological point of view, migraine, and he has been given ergotamine. So, ergot alkaloids, they can cause vasoconstriction and they may present with gangrene. So, if there is vasoconstriction, that may present as ischemia in the lower limb. So, patient may have ergotism. So, that is the answer. So, other options we didn't get from that. Okay, guys, that was the short session about whatever the questions, pharmacology questions we had for the recall, and hope this helped you a lot. And any queries, any additional options, you can put it in the comment box, and we'll try to get that options for you. And any additional questions can be added here, and that will be answered in the channel. So myself, Dr. Bharath Kumar, you can also join me in Telegram, that is Dr. Bharath's Pharmacology. There you can add up. So thank you all. Thanks for your time. Take care.